Hi everyone. Today we're going to talk about the hip joint, and specifically we're going to be talking about femoral acetabular impingement as well as the hip labrum. We're going to be looking into differential diagnosis, the etiology and the pathology of those two, how to conduct a fairly simple evaluation and examination process, and we'll kind of look into the do's and don'ts from a treatment aspect as well. So let's go ahead and dig in. I have a patient that comes into the clinic complaining of hip pain, but one of the first things that you really want to begin looking at or thinking about is differential diagnosis. What could this possibly be? Is it a patient may just complain of it being in their hip, but is it referred from their lower back? Or is it because of their knee? Or is it more along the lines of an inguinal injury or an ovarian cyst? Something along those lines. So we have a pretty extensive list here of differential diagnosis. And one of the big categories that you could look into in a sports medicine clinic or in an orthopedist environment would be the athletic pubalgia or the adductor strain. Those first two right there. That can kind of put a lot of different diagnoses into that athletic pubalgia type complaint. And so those are always things that you want to be very mindful of when you're looking at the hip. Now, the hip pain, as I mentioned, could also uh, be hidden through an SI joint dysfunction. They could have one, they could have both, right? Uh, it could be something even more serious, and it could be hip dysplasia. But we want to be able to rule out lumbar pathology. We want to be able to rule out SI joint dysfunction. We want to be able to rule out any other types of syndromes or itises that it could possibly be. And so going through a evaluation process and knowing exactly what you are testing and looking for to be able to rule in and rule out other diagnoses is very important to be able to make sure that you're on the right track for either femoral acetabular impingement or some type of labral pathology. So as we start getting into the examination process, asking leading questions in your subjective process is important. Avoiding just yes or no questions uh, can be very beneficial, but you have to know the right. You have to know that person's personality or kind of get used to that person's personality before you start going down that road, because that subjective could end up taking you 10 or 15 minutes if you let them just kind of take over that process. So you want to ask leading questions, but you also want to be very specific about those leading questions. So looking for the mechanism of injury, looking for things that irritate it, and being very mindful of when they notice it and during what activity. It's important to know how long that complaint lasts. Is it just sharp and then it goes away? Or is it dull and achy and stays throughout the whole day? And then also listening to how they describe it. If it's sharp, if it's catching or clicking or locks up on them, are all very important. Oftentimes you're going to see them when you ask them about where that pain is, that they kind of make the letter C with their hand and wrap it from the front of their hip to the back of their hip. And that's what we call the C sign. And that's typically indicative of some type of either uh, femoral acetabular impingement, FAI for short, or along the lines of a labral pathology. asking them what their current level of function is, what can they no longer do without pain or difficulty because of that hip complaint, and knowing what they were able to do prior to that is also important. Something I want to know to uh, get them even better than they were before is what what type of hobbies do you have? Do you play a sport? What is it that you do for work? Or what do you like to do for fun? Because as we start going through that rehab process, those are some of my last goals that I want to hit, and to be able to get them to be better than they were before they even came in here, or better than they were before their injury. So some other very important things to know when going through that examination process is, have they had a previous injury to that area before? If they have, what is their SANE score? And that is their perceived recovery from injury. There's a pretty good study out there that shows if they rank themselves 92 or lower, then they really shouldn't be going back to participation in sport, and there is a higher likelihood that they will have a re-injury. So that SANE score is something that's important to know, and that's something that is probably a good idea to be asking periodically throughout your care of that particular patient. And I'll typically ask it about every 2 weeks, every 4 weeks, if I have to do a progress note and say, if you were to say you are X% improved, what percent would you say you are at this point? And so that's just an easy checkbox that you can add into your subjective. Some of the other questions that you're asking if you're treating athletes is, do you play more than one sport in a calendar year? Do you play more than one sport at a time? And also knowing how much time per week do they practice that particular sport, because that can kind of get into some of those overuse injuries, and as well as increase their likelihood for injury or for re-injury. Now, those that have higher BMIs, there is some studies out there that suggest that an increased BMI increases the likelihood of hip pain. And if they're a post-operative patient, then that higher BMI also leads to lower outcome scores. And so, speaking of outcome scores, the hip outcome score is a great tool to utilize for our hip patients that do come in the door. They have an ABL section as well as a sports section, and that sports section can be removed if they are not an athlete. So when talking about the pain distribution for femoral acetabular impingement, we have 3 drawings up here. About 90% of their complaints are going to be in that anterior portion of the body. So if we start there on that left area, you have that area where a lot of people are going to be complaining of it, but you have to be able to differentially diagnose if this is where what is going on there. Not where it's going on, but what's going on there. Is it hip away? Is it close to that Bear's point that we were taught? Is it an adductor strain? In males, is it a pubic hernia? Or is it kind of coming down into that anterior thigh, that rectus inflammation, that hip flexor strain? Is it where you got some guarding from that quad muscle to try to protect that joint coming down into the knee? Is it patellofemoral going on there? So just trying to think about what exactly is causing that area is very important. Then about 10% or so, I know some of these numbers are off here, but about 10% or so is they point to the low back, but differentiating if it's some type of lumbar pathology, some type of SI joint pathology, a piriformis syndrome, even a hamstring. You could be looking at a proximal or a distal hamstring injury. And then when you start looking over laterally there, that's more along the lines of the greater trochanteric pain syndrome, or even getting into some of the degenerative gluteus medius and minimus complaints that you might see there, or even when you start looking further down towards the knee, you got that runner's knee, that distal IT band syndrome. For the objective exam, we want to first take a look at their posture. That inspection is always the first thing that you're wanting to look at there. You're looking at that anterior tilt. Do you see, if you're looking at them from the side, do you see any valgus when you're looking at them from the front? How about some recurvatum or any pes planus? All of these types of issues that you're looking at there can get into some of your biomechanics that you may need to address along the way. I consider a ground up approach or a bottom down approach, and I typically will combine these two. So the ground up approach is when you start looking at that pes planus, you look at those foot intrinsics, the posterior tib area. You want to start to see if there's a lot of control going into pronation. And so if you don't, then that knee caves in, then the hip internally rotates and collapses. Then it starts to stress that hip joint and starts to stress that lower back. And if you start looking at the anterior tilt, then we know that shortens that hip flexor there, which then the antagonistic muscle of that hip flexor is the glute max, so it lengthens that glute max. We know that muscles work best at their mid-range. Lengthened muscles can't quite get those cross bridges to connect there, so they're not as strong. And so that's why we want to make sure that we address that posture at some times, if needed. We kind of get into the palpation area next, and we want to look at the ASIS, the AIIS, any of the anterior muscles. We want to take a look at that greater trochanter, palpate over on top of it, a little bit posterior to it, where the glute med and min would insert. You want to look at the adductor, obviously the SI joint, because those can mask hip and lower back complaints. Taking a look at that piriformis to see if that guy's in a spasm, and then always being mindful of the differential diagnosis and the sports hernia in males. There's often a high association there. Then we're getting into passive range of motion. We're actually getting our hands on this hip. And we want to see what happens when we take that hip into 90 degrees of flexion. Is it painful? Is it painful beyond 90 degrees of flexion? Do you have a bony block there? Does that bony block take you out into abduction? So knowing the feel of what a good hip should feel like is super important in the objective exam and takes some experience. You're going to then look at internal rotation at 90 degrees of flexion. Is this limited? Is this painful? Looking at your external rotation, looking at the extension. Something else that you guys want to be mindful of is combining that internal and external rotation. And if it's less than 85 degrees, there's an increased likelihood of some type of hip pathology. You can kind of relate that to the GERD in the glenohumeral internal rotation deficit in the shoulder and comparing one side to the other, right? And so you want to be able to compare both of those sides. Looking at the strength, handheld dynamometer, you could do a 1 rep max, you could do the 5 rep max, compare both sides. You can see if you got that bell-shaped curve there to determine if there is any type of anything else going on from a malingering standpoint as well. And obviously you want to test all of those different muscle groups, looking at flexibility, looking at Eli's test, rectus and the quad, and then going back into the Thomas test. And please, guys, control the pelvis in this case. Otherwise, it's completely useless if not. As we go through our special tests, after we've gone through our subjective section, we've noticed their posture, we've gone through their passive range of motion, we've done some strength, we've done some palpation. Now we're starting to look at our special tests. We can do An adductor squeeze test, that's just where they squeeze it for about 5 seconds there, see if that causes any adductor pain. You can do an end range abduction test. So this is just basically testing for a growing strain, an adductor strain. You take their leg all the way out into abduction and then have them activate that. That's painful. Then that could rule in or rule out an adductor strain. You have impingement testing as well. So you have your fader right there, right? You have your flexion. You can bring it up into flexion. Is it causing any pain? Is it internally rotating? Do you need to adduct it? Just kind of getting a feel like you were doing with that passive range of motion. Here's a pretty unique study that I did find for the bent knee fallout test. Basically, just like your figure 4, and you're going to let their knee fall out. You're going to measure the distance from the lateral portion of their knee to the table. You're going to compare both sides. And if there is a 3.6 centimeter difference, that is positive for the bent knee fallout test. And that is typically indicative of a labral pathology. Here again, you got the fader and the Faber that I just mentioned. You have an anterior labrum Fitzgerald test. You have that scour test, almost where you're just kind of moving the head of that humerus, the head of the femur in the acetabulum and seeing if that's causing any pain or discomfort anywhere. You have your Thomas test, as I mentioned earlier. Please make sure that you stabilize that pelvis. I see that too many times that pelvis isn't being stabilized and they have this huge rounded lumbar lordosis in their back. Again, we want to look at Eli's test. You got your ligament of Terry's test where you do your internal and external rotation below 90 degrees of flexion, kind of rotate that back and forth. You have a straight leg raise test where, yeah, that could be indicative of an avulsion fracture of the hip flexor, could be a hip flexor strain, but it also does increase the pressure inside the hip joint. So that's something to consider there as well. And that's one of the reasons why we do not do straight leg raises with our hip patients. Again, you may want to consider doing your SI joint clusters as well as your repeated lumbar movements if something during the subjective portion kind of raises some flags towards lumbar or SI joint. I always like to take them into some functional testing after this. I'll oftentimes, if they're athletes, then they have been asked to squat to 90 or below 90 in their high school gym or even in the weight room, and that often creates a lot of bony contact once you start getting to 90 or below, and that can really start to flare up any type of impingement. And you start getting that impingement flared up, then that just pinches right on that labrum and it starts to flare. So I want to see what that looks like. I want to see if that causes them any pain, and that is something that will be noted in their chart. You got your overhead squat reach test. You can tell a lot on this particular test. You can tell if they have a strong core, if they're wobbling back and forth. You can tell if they lack ankle mobility, if they come up on their heels as they start to squat down. You can tell if they have tight lats, if they can't raise their arms up over their head. And so you can tell how their whole system is working together off of this particular test alone, and that will be a good way to start adding in some specific activities for them. You can also get into the selective functional movement screen or the FMS and start looking for anything where you got zeros and ones, as those are predictive of future injury. Now, I also like to see what type of proprioception and motor control and strength that they have. So I like to do something similar to the STAR excursion. I like to see what they can do by bringing their leg in a single leg balance position and how far back they can go. I like to see what they do posterior lateral, as well as anteriorly there. And then you can do the same thing for the upper quarter Yeah, if a baseball player, yes, you need your hips, but yes, you also need your core. You also need your scapular mobility and stability, thoracic stability, thoracic mobility. So you can do that same type of test with the upper extremity as well. So don't forget to throw in those dynamic balances to be able to test strength, test core, test proprioception, uh, motor control. All very important in looking at the total picture. Now, let's get into some FAI here. And FAI, as you know, is a condition where there is abnormal contact between the femoral head and the acetabulum. As those continue to contact over and over again, it results in damage to the hip joint and the structures within that hip joint. You keep hitting bone up against bone, that creates friction. That friction creates heat. That heat creates inflammation. And that actually starts to stimulate more and more bone growth in that particular area. So it's really a premature contact between that proximal femur and the acetabulum. And you can see down here the criteria for the diagnosis of this FAI is that abnormal morphology of the femur and or acetabulum. You have that premature contact and you have that repetitive motion resulting in continuous insult and the presence of some soft tissue damage as well. So when we start thinking about this, how to diagnose FAI, we start listening to their different symptoms that they have. They may complain of clicking, catching, popping, stiffness. Sometimes they even say it kind of gives way on them. They go to that C sign again. They have pain with running. Sometimes they'll have pain with sitting because of where they don't have they don't have their hips higher than their knees, and then in that chair their knees are actually higher, so it kind of puts them in that 90-degree position or greater. Pivoting, squatting, these are all different movements that can actually put that hip in a vulnerable position. That pain can be sharp. They can describe it as aching, and sometimes they even describe it as a constant pain that is there, especially if it's really flared up. The clinical signs that you're going to see is going to be limited internal rotation. You're going to have a positive fader, possibly a positive Faber, and that bent knee fallout test as well. And then finally, you have to have those radiological findings of a cam, a pincer, or a mix of both of them. And then you will often see a diagnostic hip injection to confirm if that is where the pain source is coming from. They'll probably go into doing some PT, and then they will have to go through an arthrogram, so an MR with an arthrogram where they'll inject that dye in there. And most insurance companies are going to want to see you doing some PT prior to getting that arthrogram, and so that's why they order that PT. Treatment options, mostly conservative care. We want there to be a PT first mindset, and if it doesn't get any better in 4 to 6 weeks, especially with PT and an injection, if it's not better in 6 weeks, then surgical intervention is required. Now, it may not get fully better. You may get from a 7 or 8 out of 10 down to a 3 or a 4, and that may be just enough to get you to keep on kicking the can down the road and trying to get that hip calmed down. And I've seen plenty of patients where they've come in with a 6, 7, 8 out of 10 pain. We've gotten their pain down to a 2 or 3 by week 6, and then within the next 6 weeks, we've completely abolished or eliminated their pain, and they were able to go on with their life without any type of surgical intervention. But there's also those that do not improve, and surgical intervention is required. So etiology. The exact cause of FAI is not always clear, but it is believed to be from a combination of genetics as well as environmental factors, right? So it could be that repetitive squatting from an environmental standpoint, or genetically could be some hip dysplasia, okay? Now, environmental factors, other things could be early sport specialization. And something that is different today than it was in the past is that now kids will play baseball all year round. And if you can delay that specializing in a single sport for as long as possible, now what they're recommending is 14 years old before you start to specialize. Now, they're also recommending that you only, I'm going to go on a soapbox here, but they're also recommending that you only play one sport at a time and you participate in sport less than 8 months, that particular sport, less than 8 months per year. And then you don't want to practice any more hours per week than the athlete's age. So again, no more hours per week than the athlete's age in years. And you need at least 2 days of rest per week when it comes to a sport. Rest and recovery is vital, and it is often overlooked in organized sport and in AAU and in club ball and in the other baseball leagues, so or basketball leagues or whatever sport it might be in. But they do need rest and recovery. Something else to think about, young athletes whose ratio of organized sports to free playtime, right, should be 2 to 1 hours per week, 2 to 1 hours per week. And if they do have this, they have increased odds of having a serious overuse injury. So if you do 2 hours of sport and you only have 1 hour of playtime, you are going to double your risk of, it's almost double, 1.87 of getting a serious overuse injury.
Here's what I found.
For those that ended up making it to the big leagues or are professional athletes, I'd want to ask you guys, do you know what their mean age of sport specialization was? So when did they start dropping those other sports? It was actually 14.1 years old is whenever they started dropping all those other sports. And here's another statistic here. So before the age of 14, only 24%. So if they specialized before the age of 14, only 24% of those kids actually made it to the professional level. And only 24% of those kids actually made it to the D1 level. If they start specializing before 12, only 5% were made it to the professional level, and then D1, only 12%. So elite athletes often specialize between the ages of 14 and 15 years old. And this was a pretty big study. It had over 6,000 athletes in it. So what do we want to do from a treatment standpoint? Okay, so the first thing that we want to do is reduce the irritability. What is it that's irritating it? We've asked this during the subjective portion of it. Is it sitting? Is it running? Is it squatting? What is it? Whatever it is, we need to reduce those activities, eliminate those activities, modify those activities. If it's something as simple as sitting or driving, then we need to raise those hips up in the air. I always teach people it's like the waterfall effect, like we would teach them from a carpal tunnel syndrome standpoint, is we want the hips higher than the knees higher than the feet. And that'll help to, and something in there to support that lower back so we don't have that excessive lumbar lordosis. We don't have that anterior tilt. Now, other things that we can do to reduce irritability is you got your anti-inflammatories. Obviously, those are prescribed by a doctor. You have your ice that you can use. You have different techniques that you can use to help to reduce that irritability. Okay, so modifying those motions, sitting, squatting, icing. You got your topical creams that you could use, your sports creams or your CBD creams or whatever it is, something to reduce those pain complaints. You have your TENS units. TENS has been very effective in helping to reduce pain complaints. Again, temporary rest from your sport or your activity and proper ergonomics. So let's get into the reducing the muscle spasms and the trigger points. What are some things that we could do here? On your own, you could be foam rolling. You could use a vibrating foam roller to get the different nerves activating there to help to reduce pain. You got a trigger point ball. You have myofascial releases that you could use. Now, when we start getting into improving flexibility of the anterior hip structures, we want to also think about how to do that. Now, you can stretch it, right? So you can do the hip flexor, you can do a quad stretch, you can do an adductor stretch, right? So those are all things that you can do as part of a home exercise program. Combine that with your foam roller and your massage creams and your ices, and you're well on your way to get that irritability calmed down and starting to get those trigger points to relax and stop protecting that joint so we can move into the other processes for rehabilitation. Now, what about the joint mobility? We've loosened up the muscles. So what about going into the joint mobs? And as we start to do the joint mobs, we want to make sure that we do a posterior joint mob. We can do lateral joint mobs with the belt. We can do an inferior joint mob. And if we need to, if they're not loosey-goosey, most females might be a little loosey-goosey, so we might want to be careful with an anterior joint mob. But our males, they're typically going to be a lot tighter, going to have a little more restriction there. So you may want to go into an anterior joint mob there. So if we start looking at regaining neuromuscular control as we've gone through this process, right? We've reduced the irritability, we're reducing the muscle spasm and the trigger points and the muscles, the glute medius and the piriformis and the hip flexors and the rectus, all those muscles. We're getting that calmed down. Now we started stretching. We've got the joint mobs going, so now we got this joint kind of moving around a lot better. Now we need to start regaining neuromuscular control. We need to retrain these muscles to make sure that they're activating correctly, because if they're not, we start getting into the strengthening portion. We might not be engaging the right muscles, and that's very important to be engaging the right muscles. So one easy one to do for the glute max is the deer in the headlights. It's a TPI exercise, Titleist Performance Institute, but what they like to do is we like for you to be able to squeeze both glutes at the same time. So I'll typically have patients relaxed with their knees bent. It's a little bit easier with the knees bent. And then we'll contract both glutes and then relax both. And I'll have them do 10 reps of those. Then what I'll have them to do is contract both glutes, left and the right. And then I'll say, all right, now relax the right, relax the left. All right, do that again. Squeeze both glutes, relax the right, relax the left. We'll go through that 10 times. Then what I want them to be able to do is just contract the right, let it go, contract the left, let it go. So now we're reconnecting that motor program from your brain down to those muscles and back up to get the correct muscles firing. We often do this with the transverse abdominis as well, right? We often will have them pull that belly button in, flatten that back, keep that back flat, and then start using different muscles, if it's or different lever arms to make it a lot more challenging. But making sure that they're not pressing too hard. You can use a blood pressure cuff, and if they're pressing too hard, then they're going to be going into a different muscle group. So it's very important to make sure that we're engaging the glute max properly. We're engaging the transverse abdominis. And we know the difference between what an anterior tilt is, what a neutral tilt is, and what a posterior pelvic tilt is. And for the patient to be able to put their pelvis in the right position in supine with the knees bent, in supine with the legs straight, and then in standing as well, because ultimately that's our goal, is to get up and stand again. Okay, so now what do we want to do? We want to start thinking about the lower quarter. We want to start thinking about balance activities, controlling that internal corkscrewing of the leg in a single leg position, preventing that genu valgus, that knee collapsing. So again, working on the core, working on single leg activities to help regain that neuromuscular control. But sometimes they don't have the strength to be able to control the femur from kind of internally corkscrewing or that knee caving in. So we have to move to the next step and build strength and come back into that neuromuscular control. So the things that we really want to start building strength on are the glute max. Okay, we want to avoid repetitive glute med work. This is going to further irritate that area, causing greater trochanteric pain syndrome, or further irritating the gluteus medius and minimus because they insert right over in that lateral hip area. Doing a clamshell, doing hip abduction, this does not do the hip any good and can only cause further irritation. Now, we also want you to avoid the straight leg raise, okay? Avoiding the straight leg raise, hip flexor work, it increases the pressure within that capsule and within that joint. It's inflamed. That is going to cause a lot of other symptoms as well. So once we start building that glute max strength, we got the motion, we got to calm down, we've really built that glute max strength up, now we can start improving functions. So we can get into things like step ups for the quads. Now, let's be smart about this, right? If we're doing a step up, let's just, and say it's the right leg, let's just keep that right leg up on top of the step. No purpose in repeatedly lifting and lowering that right leg and engaging that hip flexor and irritating that hip. Just leave it up on the top, and let's really work on building the quad strength, and let's really work on building the glute max strength. Squats, make sure they have good form and only go to 60 degrees. You are going to get the most power, the most functional power at 60 degrees. No purpose in going down to 90 degrees. You got your deadlifts, you got your stiff leg deadlifts, you got your eccentric step downs. There are a lot of different, you got your RDLs. There are a lot of different activities that we can utilize to increase the strength and even the hypertrophy in the lower extremity. And then finally, after we've improved that function, now what we want to start doing is working on getting them back to their recreational activities. And that's obviously with their pain down, their strength built back up. This could be, if these are non-operative patients, it could be 8 weeks, it could be 12 weeks. It's hard to say. You have to use your professional judgment here, but progressing them back to running, cutting, and sport-specific movements is vital for them to be able to get back to their everyday recreational activities. Start in the sagittal plane, progress to the frontal plane, and then in the transverse plane. I know that was a long slide. It took us about 10 minutes to go through those steps, but those steps are your pillars of treatment in order to return these patients back functionally. Let's wrap this up into a bow here. The treatments, the do's and the don'ts. Okay, we're going to start with the do's, but you know the don'ts are just as important. So when we talk about do's, anterior joint mobs, yes, that's obvious. We want to make sure that we do the joint mobilizations, get that joint loosened up, get that capsule loosened up. Anterior capsule stretching, absolutely. Don't forget about the para-acetabular stretching of the musculature around it, IT band, the TFL as well. Make sure that that hip isn't going into an anterior tilt there. You have your rectus, you have your hip flexor, you have your hamstring. Again, hip flexor stretching, please make sure that the biomechanics are right. Please stabilize the pelvis and don't let that hip go into an anterior tilt. Emphasizing glute max activation, super important here. Consider the max volitional isometric contraction data. You want to go low level to high. Start in supine. Get those glutes to engage. Perfect way to do that is the deer in the headlights. Perfect way to see if their glutes are engaging is that motor moron activity where you're kind of putting your fingers on the low back extensors, on the glute max, and on the hamstring, asking them to lift their hip into hip extension and seeing with your fingers which one activates, and then going into an educational series about what is actually happening if, say, the hamstring activates first, which you may very commonly see, or the lower back extensors are engaging first versus the glute max, right? So that's why we're doing those deer in headlights. Start with a bridge, progress it to a bridge with weight, progress it to a single leg bridge, making sure that the opposite pelvis, opposite hip is not dropping and everything is nice and square and oblique. Getting into kneeling hip thrusts, you can add a resistance band with that. Getting their head on the table, and then their hips laying off and bridging up that way, that hip thrust type movement. You got your kickbacks, so you can get into quadruped and work on a kickback with the knee bent. Add some resistance with either a dumbbell in the popliteal fossa or a resistance band around the opposite ankle and then around the involved foot and kicking up. Progress into standing. Do a standing kickback with the knee bent and making sure that the right posture is there and that they are doing the movement pattern right. Getting into a 45-degree Roman chair and really emphasizing and having the intent of engaging the glute max. That has been shown on that MVIC data to actually have a very high glute max contraction. You got the glute driver at some of the gyms. You got a step up and a step down. Important to note that you don't repeatedly put that foot up and down off of that step. Leave the foot on the step. Make sure that the back foot isn't you doing all the work and the foot on the step is doing all the work. Squats. Make sure you don't go below 90. Don't go to 90. Why not just go to 60? You get a lot of muscle activation there. Emphasize the glute max, the hip extension. Emphasize the knee extension on the way up to get a good glute and glute max engagement. You have a deadlift to get that glute max and those quads again. You have a standing RDL. You can get involved into those hamstrings and go into the stiff-legged deadlift, going into the RDL. You got a hamstring curl with the machine, with a ball, with the TRX, with the discs. There's a lot of different things you can do there. Now, the don'ts, super important here. I'm going to kind of go through these bottom ones real quick, but your straight leg raise, it's going to increase the intracapsular pressure. It's going to cause some issues, obviously. You obviously don't want to work on hip flexion beyond that 90-degree area. Limit the hip flexion activities. If it's going to 90 degrees, I mean, just don't do it. And then limit your internal rotation movements. Limited. If you limit those, it's just going to help to reduce the issues that the biomechanics came from, right? So repeated hip abduction. Now, the biomechanics, I could show you on a model. It just causes that femoral head to rub back and forth against that common tear area of the labrum, like from that 12 to 3 o'clock area. It's just going to cause further irritation. You got that repetitive friction between the greater trochanter and the IT band with the diseased gluteus medius / minimus. There's a high likelihood that it can cause more greater trochanteric pain and get you involved in that syndrome as well. And then I just noted here that the MVIC for the gluteus medius is the side plank. But there is something. So when I was indoctrinated in PT school, graduated in 03, we were indoctrinated in the gluteus medius, and all the literature out there in the JOSPT was all about the gluteus medius, and that's what was causing the valgus for those knees caving in. So I'm giving everybody a little history lesson here, okay? And so about 10 years later, we did a test at UTC in the motion lab with the ground force plates and the motion analysis system, and we tested a lot of previous ACL injuries. And what we noticed is, and so we had them do a depth drop, and we noticed the ones that had that valgus cave in, that genu valgus. And so what we did is we then measured their glute maxes and their gluteus mediuses. And what do you know? The glute max was the one that presented with the weakness. It wasn't the gluteus medius or minimus. So we started asking ourselves why, and it really kind of came down to the insertion line on the linea aspera of the gluteus maximus. It can actually create an external rotation moment and a slight abduction moment. So if that gluteus maximus was strong, you wouldn't see that internal rotation of the femur, and you wouldn't see that knee caving in. Okay? Now I know this is a long slide, but I also wanted to read something that when I was teaching at UTC, and this is out of Kinesiology of the Musculoskeletal System, Foundations for Rehabilitation, second edition by Donald Newman. And I want to read an excerpt out of here about greater trochanteric pain syndrome. Excessive or repetitive activation of the gluteus medius and minimus can cause point tenderness adjacent to the greater trochanter, the primary distal attachment of these muscles. This painful response suggests injury or inflammation within the hip abductor mechanism. Pain associated with activation of the hip abductor mechanism can be disabling, considering the frequently and relatively large demands placed on these muscles during the single leg support of the gait cycle. Trochanteric bursitis, as it was once known, may be caused by excessive and repetitive tension in the hip abductor mechanism or frictional stress created by the overlying IT band. More recent MRIs and clinical observations suggest that tears or degenerative changes in the distal tendons of the glute med and min at the site of their distal attachment may also cause pain in the region of the greater trochanter and associate weakness of the hip abductor muscles. So you could have some pain inhibition here. So not only do you have the biomechanics that if you're continually doing a clamshell or external rotation or hip abduction, so you have those biomechanics of the head of that femur rubbing up against that labrum from 3 o'clock to 12 o'clock or 12 o'clock to 3 o'clock or 3 to 12, depending upon which hip you're talking about, left versus right. So you have the biomechanics there of further irritating that hip labrum, but you also have that IT band there that's going to continue to cause friction along that area. So why keep doing it? It just doesn't make sense. So that is the why behind the repeated hip abduction or that clamshell activity where you're also engaging some of those external rotators. I hope that makes sense to everyone. All right, everybody, let's jump into the hip labrum and the hip labrum tear and repair along with the treatments. So the etiology, a hip labral pathology is often associated with repetitive activities, sports-related injuries, as well as or structural abnormalities of the hip joint. So could it be traumatic? Yes. We see a lot of it from the femoral acetabular impingement syndrome, and then We see it from the repetitive activities, if it's deep squatting or even possibly some type of traumatic injury. Pathology. Labral tears can be categorized as degenerative, traumatic, or a combination of both. They can be partial, they can be complete. There's many different types of tears. Non-operative treatment, we're going to go back to the same concepts that we utilized before from a physical therapist standpoint. Now, diagnostic injections are often given to see if they form some type of, or if they give some type of relief, and then they're sent to PT. And so again, it's reducing that irritability. That's through your ice, through your TENS, through getting rid of whatever is causing that injury. Going back to your ergonomics, reducing those irritants, getting that area calmed down, getting in there, reducing the muscle spasm, rolling that area out, using a tiger tail, using something to decrease the muscle spasm in that area so that you can get in there and really improve the flexibility of the anterior hip structures. And that's through the stretching that we talked about, the adductors and the quads and the hip flexors. You want to improve that joint mobility. Again, that's through all of your joint mobs. Your neuromuscular control. Make sure that you have that mind-body connection, that motor program for the glute max, for the transverse abdominis. Make sure the quads are firing. Make sure you feel it in the right muscles. Build your strength. Improve your function, your functional strength, and then return back to those higher level activities. Remember your do's, remember your don'ts, and you should be just fine with this labral, non-operative labral pathology. But let's talk about post-operative care. Sometimes this can kind of get us mixed up as well, right? Getting on that upright bike. Getting the seat right is important. Making sure that that hip does not flex beyond that 90 degrees. You're going to be putting people on the bike day one. They're not going to feel like it. So making sure they get on there. That bike, it really helps to prevent that frozen hip by pushing out that hematoma from the surgery. Right as the surgeon pulls out all those tools, blood fills in that area. So we have to pump that out. That's going to help with the range of motion. And overall, it's going to help with the pain. Now, when they're on that bike, you don't want to use your hip flexor to pull the pedal up. You want to use your glute max to push down, and you want to use your hamstring to pull it around to the top again to where you can then push down with the quad and the glute max and pull back around with the hamstring. Okay, so making sure that we are on the bike immediately is very important. You're going to be on crutches for 2 to 4 weeks. You're going to be 50 pounds weight bearing most of the time with the surgeons. You're going to be walking on a flat foot. You're not going to have any active hip flexion going on. So no straight leg raises, no seated lifting your leg up and down. You can do this later on only if you need to and they're not getting a good quad contraction, but most of the time we're able to get that good quad contraction later on. So the straight leg raise isn't something that we necessarily want to do in this particular case. You're going to get in there and you're going to do gentle passive range of motion. So they're going to be laying down on their back and you're going to be holding their leg. Remember, you're going to have 3 points of contact, your left hand, your right hand, and your chest, and you're going to be doing circumduction. You're going to be going clockwise and counterclockwise. I typically do about 30 reps or so, and I may do 2 or 3 sets. You're going to do log rolls. That's with their legs straight. You're going to internally rotate it there to a comfortable range. You're going to be able to feel that infield, and you're going to do the same thing for external rotation as well. So log roll in, log roll out. Flexion, you're going to bring it up to less than 90 degrees. You don't want to go beyond 90 degrees there these first 6 weeks or so. External rotation, less than 30. internal rotation less than 20. You're also going to get them started. I usually will do that once I get that hip flexed up to 70, 80 degrees or so. And then I eventually get it up to 90 or so. Isometrics, you got your quad sets, you have your hamstring sets, you have your basic ankle, active ankle pumps. Prone lying, so lying on your stomach, making sure we can get that hip all the way extended to neutral. Again, you want to be mindful of males versus females. Are they loosey-goosey, most of our females, or are they really tight, most of our males? And if there is a script that comes in, you want to be careful of that anterior capsule repair. So if you start to get in there and start working that anterior capsule area, you know what's going on with that particular tissue. And then I start getting into transverse abdominis activation and start really working on that core. So that's usually day 1 through day 14. They return back to the doctor day 10 through 14, so making sure there's a progress note written to the doctor so that you can start to get a narrative going back and forth. Week 2 through 4, and then week 4 through 6. So I like to break it up in this particular area here as we start having that proliferation, that granulation of all that new tissue, all that scar tissue that's lying down. That's why we want to continue to make sure that we're doing these joint mobs. We're doing our passive range of motion. We start adding in these joint mobs as tolerated to make sure that that capsule doesn't get tight. I like to put them in a side lying position for a hip flexor stretch. I like to put my body up against the back of their pelvis to help to stabilize that pelvis. And again, I like to be mindful if there's an anterior capsule repair for my males versus my females. Still doing that passive range of motion. At this point, we're going to start progressing weight bearing if the doctor is going to allow us to. So I like to look at that script when they come back from the doctor and see what they say. Eventually, we're going to start normalizing that gait over week 2 through 4. I want them to be able to walk without a limp before they get rid of those crutches. And then you're going to start progressing from some of those open chain activities where they're on the table to closed chain activities where we can actually start getting their feet on the ground. We can do standing calf raises once they can weight bear more, standing hamstring curls, standing terminal knee extensions. We can work on gait. Then we can actually start getting them onto balance activities or a step up activity, just continuously trying to progress them, focusing on some core work, some bird dogs, getting that core activated. Again, we want to avoid hip flexion activation. So as you've continually gotten them stronger, week 4 through week 6, they're getting stronger. They go back to the doctor at week 6, and now I like to start progressing them to an elliptical. This can actually help to get that hip into a little more extension, get them used to being upright, start getting a little more blood flow to the area, and then we can start working towards our hypertrophy of the muscles. That's again a weight that they can do 8 to 15 reps with. I'm going to start with low volume, but for hypertrophy you need a lot of volume. But I'm going to start with low volume and maybe 15 sets total, and then work my way up to higher volume, 20, 25 sets. Not of the same exercise, but of the same muscle group. Hopefully that makes sense. I'm going to continue working on my neuromuscular control with all my movements, making sure that the knee doesn't cave in, and the valgus, making sure that there's no femoral corkscrewing, make sure that from the ground up that the foot intrinsics are working to help to control the knee and the hip as well as the glute controlling the knee and the foot. Getting into more balance activities and proprioceptive activities so that they can really start to control that, knowing where that particular joint is in space at a particular point in time. Toward week 10 through 12, now we can start building the strength. Those are going to be some higher level activities. Strength, yeah, those are going to be about 3 to 5 reps, 3 to 5 sets, 3 to 5 exercises, 3 to 5 minutes in between each particular set. Week 12 and beyond, so 5 to 6 months if they're returning back to a sport, you're going to start working on return to running if they have enough strength and they have enough control. So making sure you have a good return to running program. You can begin more progressive agility at this point in time. Again, they have to have the strength. They can't be coming back super sore, etc. They have to be, their body has to be right for these particular activities. You're going to continue to build that strength, progressing into sport-specific movements if appropriate. Now, once they get to month 4, then we can start getting into a jump program. We can start working on our depth drops, making sure that they have good control, making sure that they're landing soft, making sure that they can hold that position, their knees aren't caving in. Then you can start adding the counter movement. So you got the depth drop with the counter movement. So we can start adding that in there too. Using your professional judgment based on their strength, based on their proprioception, and based on their motor control. I'm going to go into a little bit more depth on this very next slide here in order to determine if we're going to discharge them or if it's a return to sport activity. So I'm just going to, on this left column, I got the 40-year-old female. They're at 4 months. We want to know what their goals are. What are your goals for this particular patient from a range of motion and a strength standpoint? What is the communication from the surgeon? Are they still having pain? Are they doing really well? You have to manage their expectations. So you have to have seen enough of these patients to know what happens down the road or where they should be. What's their maximum medical improvement? What's that timeline? What do they need to continue to keep doing? What was their prior level activity and what's their current level activity? Where are they at exactly? What is their hip outcome score? Do they want to return back to running? What is their return to running program? If so, is it jogging? Is it running? Is it distance? What do we need to do to get them back to what they want to do? And then or would they just rather get back into the gym environment? Or are they more of a sedative lifestyle and they don't want to get back to those activities? So that might be the case to discharge them at 4 or 5 months for this particular lady. If it's a high school athlete or even a weekend warrior, month 3 and beyond, it's go time. You got to have, if they have the right strength, if they have the stability, the motor control, the hypertrophy, they're pain-free, it's time to get it, man. It's time to get back to the return to running program, your sports-specific activities. Make sure that they can decelerate before you start teaching them to accelerate. You want to get them back into your cutting and your agility programs. You want to get them back into that jump program like I mentioned before at 4 months. You start with that depth drop, you get into that counter movement, you work on the jumps. Jumps are 2 feet. Then you progress into hops. Hops are 1 foot. You start working on your distance hopping, your 3 distance, and you start working on your 5, and you work on your going back and forth across the line and sticking. You have all the different jumps to be working on. And then when it comes to sport specificity, we want to make sure that we utilize their sport demands and we utilize their position demands as well. I'm not going to treat a offensive lineman the same way that I'm going to be treating my running back. They have different demands in their sport, or even my basketball player. They all have different demands, and I need to take that into consideration. Are they more aerobic? Are they more anaerobic? What are their movement patterns? Those are all things to consider. And if you have a good resource, these demands are already out there. Remember, you want these patients to be better than they were before they had their injury. I want them better than better. I want them 110%. And that's something that's going to get these patients to know you, like you, trust you, and then you're going to be their physical therapist for the rest of their life. And that's what it's all about. So hopefully everybody found this useful, learning about differential diagnosis, learning about a evaluation and an examination, learning about the FAI, the do's and the don'ts, your treatment pillars, learning about the labrum, the do's and the don'ts, and your post-operative care. That's going to conclude our discussion. We were able to sneak it in just under an hour, and I hope everybody enjoyed it. If you have further questions, I'd love to have a conversation. Thanks, everyone. Have a great day.